Good morning, good afternoon, and good evening to you all, depending on where you are joining from. My name is Sylvester Moyo, and I'm delighted to be your host today. Today's AMR Committee of Practice session will focus on understanding the EUCAST guidelines for antimicrobial susceptibility testing. We will delve into the history and overview of EUCAST guidelines, their interpretation, and explore the EUCAST website assets to learn how to effectively use them. This session serves as a foundation for a second webinar that will cover the practical aspects of the EUCAST methods. So please be aware of the second session of this CoP session. So as we know, accurate and standardized AST is a cornerstone in the fight against antimicrobial resistance. EUCAST plays a pivotal role in providing harmonized guidelines essential for clinical decision-making, policy development, and laboratory practices worldwide. Today, we will gain insights into how these guidelines have evolved and how they can be effectively implemented in various settings. Please note that this session is 1 hour long and will include a question and answer segment towards the end. Throughout the session, we encourage you to share your questions and comments via the chat box, and we will address them towards the end of the session. Please also note that there's simultaneous language interpretation from English to French and Portuguese that can be accessed via the interpretation icon on the toolbar at the bottom of your Zoom screen if you're using a PC, laptop, or smartphone. Please click that interpretation icon and select either English, French, or Portuguese based on your preference. It is a privilege to introduce today's esteemed presenter. Professor Gunnar Kahlmeter is a senior professor and a current technical data coordinator of EUCAST, which is the European Committee on Antimicrobial Susceptibility Testing. He is a clinical microbiologist since 1971, and Prof. Kahlmeter has really dedicated over 5 decades to advancing the field of microbiology and antimicrobial susceptibility testing. He served as the chairman of the EUCAST from 2001 to 2012 and was the president of the European Society of Clinical Microbiology and Infectious Diseases from 2012 to 2014. Prof. Kahlmeter has been instrumental in shaping the global AST standards and has served on several breakpoint committees over time and over more than actually 25 years, including committees in Sweden, the UK, Europe, and also served as an advisor for CLSI for 12 years. In today's session, Prof. Kahlmeter will provide a comprehensive history and overview of the EUCAST guidelines, discuss how to interpret these guidelines, and guide us through the EUCAST website assets, showing us how to utilize them effectively in our work. His presentation, as mentioned, will lay the groundwork for a follow-up webinar that will delve deeper into the practical aspects of the EUCAST methods. Prof. Kahlmeter, it's really a privilege and an honor to have you on this session. Over to you.
Thank you very much, Sylvester. It's a privilege to be here. And I wish I could meet you all instead of sitting here in front of my screen up in cold Sweden. That would have been much more fun. But things are what they are, and nowadays Zoom and Teams and what have we not rules. So that's how it is. So I'm going to introduce you to EUCAST, and I'm going to try to explain some of those questions and worries that you may have. I will speak, or rather I will try to speak more slowly than I would normally do, and that is in order for the translators to have a chance to actually translate what I say. So good morning, good afternoon, good evening, wherever you are in the world. I shall exhaust my French by saying bonjour. That's the limit of my French. So, EUCAST was created by ESCMID, the European Society, and 6 national European breakpoint committees back in 2000, roughly. It's organized and financed by ESCMID, but nowadays also with the very formal help of the European Centre for Disease Prevention and Control. EUCAST is since more than 20 years acknowledged by the European Medicines Agency, by the UK agency, and also by ECDC. EUCAST is supported by national AST committees, and if you're not quite sure what those are, I urge you to go to the EUCAST webpage and look under organization and then under national AST committees, because EUCAST has encouraged all countries, irrespective of whether you are on EUCAST guidelines or CLSI guidelines, to actually form a national AST committee to be a contact point for CLSI or for EUCAST, depending on which guideline you are following. So read more about what national AST committees are all about. There are about 40 countries around the world today that have what we call NACs, or national AST committees. It's a good and helpful thing, and it helps out with everything from translations to education to consultation with EUCAST, etc. So if you don't have a NAC, think about forming a NAC for your country. But EUCAST is more than just the various national committees and the Centre for Disease Control, etc. It is a platform for participation with colleagues all over the world. And very typically, and since more than 10 years back, every major decision has a 6 to 12-week period of general, or if you like, public consultation, where anyone who has an idea or experience or scientific evidence can inform EUCAST of their standpoint and influence EUCAST decisions. So that's important for all of you, especially when you have an area of interest where you are expert. We thrive on the input from experts from all over the world. The website at www.eucast.org now has more than 80,000 unique page downloads per month and roughly 200,000 unique page views per month. So someone is using the website and the EUCAST system. EUCAST is organized along the following lines. There is a general committee where each country can submit one representative. And the only thing we require is that there is some formality behind the submission of the national representative. It could be a society, it could be the government, the health department, etc., etc. That will submit a name for the general committee. And again, under EUCAST and organization, you can see all the names of the general committee representatives. They are normally also the NAC chairs, but not always. Then there is an operative steering committee of 12 experts, including 2 representatives of the general committee, and they take 2-year rota terms, so that anyone on the general committee will eventually probably serve on the steering committee. The steering committee has 5 2-day meetings per year, and that's where the majority of our business, if you like to call it that, is done. As I said, there are several public consultations per year, and if you want to have a look at them, you go to the EUCAST webpage, and you go to the left-hand margin, and only a few choices down, you will see public consultations. And you can read the ongoing one, which is on endocarditis breakpoints, and you can also see all the other consultations, what people thought, and how EUCAST responded to these. There is a EUCAST workshop at ECMID, and ECMID, as some of you will know, has just changed name to ESCMID Global, and that workshop is each year. We participate in all ESCMID activities, in study groups, in summer schools, in expert functions, etc. And we have two EUCAST development laboratories, one for bacteria and one for fungi. These will take care of the development of new methods for new species, for new agents, but they will also generate criteria for quality control and also for guidance documents. On top of that, we have fostered over the years an international network of dedicated laboratories all around with expert interest areas. And that means that we can tap into the expertise of specific laboratories in many places, in Australia, New Zealand, South Africa, South America, the US, etc., etc. And there are colleagues with keen interests in unusual bacteria like Vibrio non-cholera species, etc., etc. Listeria, Kingella kinga, Campylobacter. And we tap into these expertise areas and we set up laboratory clinical trials together with these colleagues. This is just to acknowledge some of those that have been instrumental in the progress of EUCAST over the years. Ian Phillips started EUCAST in 1997. I was asked to take over in 2001 and ruled for more than 10 years. Then Rafael Canton of Madrid took over, then Christian Giske at Karolinska, and now Søren Gartemann from Bochum in Germany. Our scientific secretaries have been Derek Brown to the left in that picture where we are rinsing mushrooms. In the middle, John Turnage from Adelaide and Australia, and Mandy Wootton from 2023 from Cardiff in the UK. This is a typical steering committee meeting at this point in time. We meet every other time over Zoom, and during the pandemic, the COVID pandemic, we met over Zoom only. Nowadays, we meet physically every second time and over Zoom every second time. These are the two EUCAST development laboratories. Top, the bacterial one, which is under in my lab with Erika Matuszek, who will lecture to you in a week or so, and Onur Karatuna and Jenny Orman. And down below is the EDL, the EUCAST Development Lab for fungi in the State Serum Institute in Copenhagen, headed up by Maiken Kavling Arendrup. Already Fleming developed a broth dilution technique with turbidity as the reading endpoint. And apart from the fact that we have made sure that this can be done in a micro broth format rather than in a format with all the big vials, it's basically the same method we're using today. It's probably better standardized today than it used to be, but basically it's the same method. The WHO commissioned the International Collaborative Study, and they presented their summary and results early 1960s, but it was never properly accepted by everyone. And what then happened during the 1970s was that all these national committees were formed, including the NCCLS, which later became CLSI, and also the national committees in the European countries. So everyone knew best, and everyone had their own system. Everyone had their own disk diffusion test. Everyone had their own breakpoints. And an E. coli isolated in Paris could be susceptible. And if the same E. coli was isolated in Rome, it could be resistant. During and following the restructuring in 2001, I was asked to chair, and what I did was I asked all the national committees to take part, and I said, this is actually your responsibility. If you do not want to play ball, we can never standardize and unite behind one system. And everyone raised their hand and said, we're in, we will do this, we will help standardize, and we will compromise, and we will find a scientific method to do this that we can all agree on. And since 2001, EUCAST has worked in a very structured and scientific manner. We have had differences of opinion. We have never voted because we don't believe in solving scientific problems by vote. If there is a problem which we cannot agree on in science, we table it and we continue to work and we search for more knowledge, and eventually we agree that this will be the way forward. In 2003, over 2004, the European medicines decided to put together a memorandum of understanding where EUCAST was invited to propose European breakpoints, both for new and old antibacterial and antifungal agents. And it meant in reality that we became the breakpoint committee of EMA. We do not decide the breakpoint, but we propose the breakpoints to EMA, and they have so far accepted our proposals. And the next cornerstone from our point of view was when EU decided to assist ESCMID in backing EUCAST financially, and that role was later taken over and is still with the European Centre for Disease Control. And that gives us a lot of stability, the fact that EMA is behind us scientifically, the fact that ECDC is behind us scientifically, and the fact that ESCMID and ECDC backs us financially. It also means that we are completely free from backing by industry, and our decisions are not influenced by industry in that manner. It doesn't mean that we don't listen to what they say, but we do not feel obliged to follow any advice that comes from industry just because they would have been backing us financially. In the beginning, everything was simple. The MIC was absolute. And I'm pretty sure that there are many colleagues who still believe that the MIC is an absolute mathematical value which can be compared to serum concentrations and that you can draw conclusions from. That is not the case. The MIC is a relative value which will change with whatever circumstances surround the testing. You can juggle the MIC any which way you like by changing pH or the medium, calcium content, etc., incubation time, inoculum, etc. So please remember that the MIC is a relative measurement, and it's not something that God or Allah has given to the bacterium, and which is sort of an inherent trait of the microorganism. It's easy to believe that MIC are absolute because they have so many decimals. But remember, this is what happens if you divide 1 milligrams per liter in twofold dilutions. You will eventually have very many decimals, but it doesn't mean that these values are absolute or accurate. Since then, we have tried to construct very many algorithms, and the latest fad, of course, is to develop PK/PD criteria. And some of you will remember that EUCAST had in their breakpoint tables a tab called the PK/PD breakpoint tab, which has now been removed because we eventually realized that the PK/PD was also species-specific, and that PK/PD for a Pseudomonas aeruginosa infection would look different than the PK/PD for a Streptococcus pneumonia infection, and that a lung infection would look different than a wound infection. So the PK/PD breakpoints have been removed, and we certainly urge everyone not to use the PK/PD breakpoints for anything except to think about dosing and modes of administration. In the old days, all species shared the same breakpoint. That was very practical. And this is an original NCCLS table from 1981. And you can see that all agents are actually basically crammed into one page. And you can see that the disk content leads, and then the zone diameter for resistance. And the MIC is really just a very loose correlate to the breakpoints, which in those days were listed as zone diameter breakpoints only. Now, many years later, it's much more complicated, not only with EUCAST, but also with CLSI. And this table happens to be a EUCAST table. It could almost also be a CLSI table, lots of footnotes, different breakpoints for community-acquired pneumonia as compared to, let's say, bloodstream infections, etc. And that has made susceptibility testing more complicated than it was. And you can be sad and sorry about that. It's irritating. It makes everything more complicated and probably more expensive, but it's just the way it is. And with the ongoing terrible outbreak of antimicrobial resistance, this is absolutely paramount that we learn how to navigate between resistance mechanisms, between different species, and between different agents. So in 2024, EUCAST has become a very solid and organized organization with financial independence and without any commercial dependence. There is a decision process which is based on science and agreement between colleagues, and there is a public consultation process which allows everyone outside the committees to also have input into the decision process. It doesn't mean you will always get it your way, but it means that EUCAST will read what you wrote and what your opinion is and what the scientific evidence you brought forward is, etc. So the public consultation process is very important to us, but it's also very important to you. Every point that is made during the consultation process will have a response from EUCAST. And when you go to the consultation page of the EUCAST website, you can read not only the document that we put out for consultation, but also the comments from colleagues that came in as the consultation went on, and also the response given by EUCAST to the comments. Importantly, all breakpoints, all guidance, all documents, all methods are freely and easily available via website. There is no secret depository where you could have had more information if you had paid to be part of it all. You are part of it all, whether you like it or not. And everything which we are prepared to recommend is posted on the website, and there are no secret corners of the website, so everything is available. What I see and what you see are exactly the same. There is also a long file of frequently asked questions and the EUCAST response to those questions. And those are often very helpful because most of the questions you will have already been posed, and we will have thought about a proper answer, if you like, a well-formulated answer, and that can be found among the frequently asked questions. But when everything else fails, there is a user help desk accessed via the website email system, and I think I can say that when someone mails EUCAST for advice, you normally have a response within anything from 30 minutes to 2 days. And we are very proud of the fact that we are always available for advice. I think we've already said this, so we'll jump. And this is the EUCAST webpage, www.eucast.org. And you can find, as I said, all the information you would like on this page. Clinical breakpoints and dosing are up here in the left-hand margin. You will find the EUCAST news section here, but you can also find the news in the right-hand margin, the latest news at the top. And if you want to sign up for a newsletter, you go up here to the newsletter and you click and you leave your email. You won't be charged anything, but you will have a summary of all news at the end of the month. And it's an automatic function. Methodology that you will talk about later, you can find down here, AST bacteria, AST of mycobacteria, AST of fungi. So the EUCAST website will take you a couple of weeks to go through, but it's most probably worth the effort if you're a clinical microbiologist. This is just to show you what happens with the unique page views over time. And you can see that the green curve is from 2020, and we then have some 100,000 page views per month. And the dark blue is from this year, and you can see we're now dealing with 150 to 200,000 page views per month. And we realized that that gives us a lot of responsibility to keep everything moving, to be up to date, to make sure that we review and revise when relevant and necessary. And this is just to show you that Europe, and remember, EUCAST originally was a European committee. Nowadays, it's much more of an international committee, and there are many countries outside Europe that have decided to go EUCAST, and you can see some of them at the bottom there. We've quite honestly lost track of which countries have decided to go EUCAST and for which countries EUCAST is the preferred system. There are lots of publications out there on everything from methodology, to breakpoints, to rapid AST directly from blood culture bottles, which is a whole section on its own. And if you're into bloodstream infections and rapid diagnostics, then I urge you to go to the EUCAST website and read the EUCAST rapid AST directly from positive blood culture bottles. It works really nicely. And today, there are hundreds of laboratories around the world who are using that as an everyday routine to provide rapid AST reports to their clinical colleagues. We're down to 4 hours from a positive blood culture with an E. coli. We can give a report to the clinician within 4 hours of the positive signal in the blood culture. So we've dealt with one agent after another, and then one species after another. And you keep complaining about some species not having breakpoints and some agents not having breakpoints. And I fully understand you. And the only thing I can say is we're working constantly to improve the list of agents and the list of species that have breakpoints and methods. These are the agents that we have worked our way through. There are more agents than these actually, but some of them didn't fly and were never registered. So they are not on this list, despite the fact that we did what we were expected to do. One example could be plazomicin, which we did everything we were supposed to do, but it was never registered in EMA. And then down in the right-hand corner, you can see that there is a flurry of antifungal agents. I've just summarized them under antifungal agents, and you can find all of them in the breakpoint tables for antifungal agents on the website. These are the species, all the Enterobacteriales, the Pseudomonas species, including other Pseudomonas than Pseudomonas aeruginosa. And we have looked at 6-7 other species to make sure that breakpoints work also for these. Acinetobacter baumannii, Stenotrophomonas, etc., down to Campylobacter and Kingella and Aerococcus and Aeromonas, Neisseria gonorrhoeae and meningitidis, and we're now dealing with all the anaerobes. We have dealt with those 6 listed here, and we're currently dealing with another 6 more, and they will be available during 2025. We recently dealt with Vibrios, we dealt with Corynebacteria, Corynebacterium diphtheria and ulcerans. We have dealt with Burkholderia pseudomalae, Bacillus anthracis, Brucella melitensis, and we're now dealing with reference methods related to Mycobacterium tuberculosis and other mycobacteria. And actually, the day before yesterday, we had a major Zoom meeting on deciding on the reference broth microdilution method for MIC testing of mycobacteria. We're still struggling with nocardia, but we think that during 2025, we will have criteria also for nocardia. Does that mean we have finished? No, there are more species, and there are always more species coming. And with the advent of Malditoffs and the likes, we find species that we previously had not heard of or could spell. And that means that we constantly have to develop new methods and new breakpoints. I would also urge you to take a look at the list of EUCAST guidance documents. Not everything is suitable for a numerical number. And then it's very important that we can give guidance on how to use tables, what to do. And you can see down the list there are guidance on Legionella pneumophila, there's guidance on breakpoints in brackets, there are guidance on aminopenicillin breakpoints for Enterobacteriales, etc., etc. So you may find something which is of importance to you among those guidance documents, and I just urge you to go there at one point or another. CLSI, EUCAST, and FDA all use the same tools for setting breakpoints. It's not so that EUCAST has different tools than CLSI. or FDA. And CLSI and FDA have the same tools, but they actually come up with different results. So depending on which agent or which species we are discussing, there might be rather big differences between a CLSI breakpoint and an FDA breakpoint, and between a EUCAST and CLSI breakpoints. The only thing I can say about that is that people are different, people have different views, people look at things from different angles, and all of this makes it improbable that 2 committees or 3 committees will come up with exactly the same numerical numbers. There is an ongoing process, and I would like to just stress that there is an ongoing process whereby EUCAST and CLSI attempts to standardize things that can be standardized without too much trouble or effort. One of those things, for example, is that we are now absolutely united in how to develop disk contents for new agents. It will hopefully never again happen that CLSI and EUCAST for a new agent will recommend different disk contents, because we're both part of the same disk content process, and we discuss until we agree. Otherwise, both committees, or all 3 committees, because FDA sets their own breakpoints, use the same tools. We need the microbiological data, we need MIC distributions, and we need to know which infections are relevant or considered relevant, and we need to know what there is to know about PK, pharmacokinetics, and pharmacodynamics, and we need to know what dose is planned to be registered, and what that dose will do to exposure at the sites of different infections. It is completely different to develop breakpoints for an agent which is only going to be used for banal urinary tract infections, compared to developing breakpoints for an agent which will be used both for banal urinary tract infections and bloodstream infections. And it would be highly unlikely that the breakpoints would be exactly the same for a urinary tract infection and for a bloodstream infection. So we need to know all that before we start discussing the breakpoints, and we need to have proof of concept. We need to look at clinical outcome data by target species. We want to know, is there a difference in outcome between Staphylococcus aureus and E. coli? Is there a difference in outcome between urinary tract infections and skin and soft tissue infections? Is there a difference in outcome depending on how high the MIC is? And also, is there a difference in outcome related to very typical resistance mechanisms? Will this agent work for MRSA and MSSA? Will it work for ESBL producers versus those that do not produce ESBLs, etc.? And also, we like to evaluate clinical outcome by whether the agent is completely wild type without any resistance mechanisms, or whether it has 1 or 2 or 3 or very serious resistance mechanisms. After all, we perform susceptibility testing to predict clinical outcome. That's the whole point. But we also do it for AMR surveillance. And most people will so far have used the clinical breakpoints for AMR surveillance. But to be quite honest, it would have been much better if we had used epidemiological cutoffs for surveillance and divvied up bacteria into those that are without any resistance mechanisms and those that have some or many or serious resistance mechanisms. It would have been made life easier, and comparability over time would have been guaranteed. But with the changes in clinical breakpoints, both within CLSI and FDA and EUCAST, it makes it very difficult to compare resistance development over time when breakpoints change over time. Susceptibility categories in EUCAST is S, I, and R. Nothing very exciting there. Susceptible at normal exposure. And the I is susceptible at increased exposure. Many of you will be used to having the I as a buffer between S and R and to not really know what exactly to do with an I. Remember that in the current EUCAST system and with the breakpoints that we have reviewed and revised over the last 5 years, we have these two susceptible categories: susceptible at completely normal dosing, normal exposure, and susceptible at an increased exposure. That means the infection may be in a place where you can utilize the fact that pharmacokinetics will increase the concentration beyond what you would normally see in serum, or you could increase the concentration at the site of infection by increasing the dose, or by changing from oral to parenteral, or going from parenteral IV injection to parenteral infusion, etc. The good thing is that R for resistant is resistant, just as before, irrespective of exposure. Then you need to know also that in the EUCAST table, some breakpoints are in brackets. And that means that they can be reported susceptible under certain conditions. And those conditions will be listed in a footnote beside the breakpoints. A dash in the table does not mean that EUCAST has not dealt with the agent. It means that EUCAST has dealt with the agent and that you can consider the agent completely unuseful in relationship to the species. So you can, if you have to report something, you can report an R without testing. So don't test anything with a dash, just report R if you need to report anything. An IE means that, yes, we have dealt with the breakpoint and the agent. There wasn't sufficient evidence to determine a breakpoint. And that leaves the field open for your own assessment if you need to do that. And then there is a document called, among the guidance document, called What to Do When There Are No Breakpoints. And you can go to that document and you will have advice on how you can deal with agents where there is an IE in the table. And then, of course, EUCAST is known for listing MIC distributions systematically on the website and for assigning an ECOF to every agent species distribution, which will divide or distinguish between those that have no resistance mechanisms at all and those that have one or several resistance mechanisms, irrespective of whether they are clinically relevant or not. And that then we talk about wild type versus non-wild type, and the breakpoint, if you like, is a microbiological breakpoint and is called the epidemiological cutoff. And that's what I use very much for finding out, for determining whether a bug has any resistance mechanisms at all. And I do that before I start advising my clinical colleagues. And these are the definitions then. You can see there are two green definitions, normal exposure and increased exposure, but both of those, the S and the I, are susceptible. And then, of course, you have the red for resistant, and the distribution you're looking at is the Streptococcus pneumonia distribution of MIC values collected from all over the world. There are 37,000+ MIC values from all over, from 32 different investigators. The clinical breakpoints are S less than or equal to 0.06 and R more than 2. And then you can see the ECOF is 0.064. Anything under a blue bar is considered completely without beta-lactam resistance mechanisms. Anything in a red bar has one or several resistance mechanisms of varying severity. Here's the same thing, but for an E. coli, for cefotaxime, and you can see the distributions are very similar. There are always 3 to 5 blue bars, and then for those where resistance is known, there will be some or many short or tall red bars. And in this case, you can see there are 44 contributors and 10,000 plus observations. That's the wild type, and you can see the ECOF is 0.25. This is what it looks like when you then take that to disk diffusion, and you can see the green bars are representing the wild type. The red bars are representing those that are resistant by the clinical breakpoint of R more than 2, so 4, 8, 16 and upwards. And then we always have an area of technical uncertainty in the middle where we're not quite sure because of the expected overlap between different MIC values once it goes to zone diameters. All of this is available to you on the website, the traditional website to the left. And when you click on MIC distributions down the left-hand margin, both the MIC distributions and the zone diameter distributions will be available to you. It's now 12:47, and I think we will break here for questions. If there are any questions, you can post them directly to me or via the chat. So I'll stop here, and you will have the presentation available to you. There are a few more slides. They are self-explanatory, and you can either just read that, or you can write me an email, and I'm happy to help. So with that, I will just stop the presentation. I will stop sharing, and or shall I leave the sharing on, maybe, Sylvester, in case?
Yeah, that's okay. I think in case that there are some questions, so we have been taking a close eye on the questions for you, Prof. But really, thank you so much, I think, for the presentation that you've given. Really valuable information coming through. I think it's key. Some of the key takeaways that I've taken from you. I think we are really trying to, support countries in terms of thinking around AMR surveillance. I think your aspect about ecological cutoffs being, much better to use, and as they provide guaranteed comparability over time, I think that's one key takeaway that I think maybe countries should look at, because you mentioned that breakpoints really, change over time. The other part, glad to know that CLSI and EUCAST are collaborating. I think we've had a lot of questions from labs in terms of disk content. So I'm really glad to hear that you are collaborating, and now aligning in terms of new agents. And then lastly, I think really you really nailed it when you said, continuous improvement. You seem like you have your hands full. You're always improving, getting more information, to try and provide useful information out there. So with that, I think I will go into the questions. We have a couple of questions online. So I will go to the first question. And this question is coming from, I'll just pick randomly, Daouda Torre. He asked in French, but he's really asking, why should a lab choose the EUCAST standard over the CLSI standard?
Yeah, that's a good question. And I think there are some reasons for staying with CLSI. If you've been using CLSI for many years, you should not abandon a standard lightly. It has to do with things like continuous updates. Can you afford to get the continuous updates for CLSI? Or are you in an economical situation where you then prefer to use an old standard because you've already paid for it and you don't feel like updating and paying for new updates every year? The EUCAST, what speaks in favor of EUCAST here is really that all recommendations are sort of updated in real time, and you don't pay anything, and you are alerted by email and by newsletter and by, you know, whatever. So you're sort of part of the system. And I think that speaks in favor of CLSI. But quite honestly, you know, a lot of the recommendations are very similar nowadays. The breakpoints may differ a bit, yes. I think one of the things, or one other thing that speaks in favor of EUCAST is that we don't like leaving things the way they were just because that was the way they were. There are many breakpoints in the CLSI system that haven't been revisited for 25 years. And that means that a lot of the many breakpoints in the CLSI system are based on old traditions. And the data is based on other organisms than the actual organism which is in the table. So when we give breakpoints for Vibrio cholera, or for Vibrio parahemolyticus, or for Corynebacterium diphtheria, or whatever, we base it on data, modern data for those bugs. And we have put the money in there to make sure that we can develop whatever needs to be developed on a modern setup of actual bacteria. So the Corynebacterium diphtheria were developed only last year together with the Pasteur Institute in France and the Food Safety Institute in Munich and colleagues in Canada. So I think that speaks in favor of at least making sure that the recommendations that you use are based on a reviewed and revised and modern system.
Thank you so much, Prof. There's an interesting question that came up. I think this is basically from a researcher, most likely. So I think you highlighted the part about insufficient evidence. Like you say, you've looked at it, but you don't have such insufficient evidence for that. The question is, where can we find this documentation? I think this is a researcher would like to find out if they can read more and explore.
Yeah. You go to a document called What to Do When There Are No Breakpoints. And there is a link to that document under guidance documents. So in the left-hand margin of the EUCAST website, you click on guidance documents. And I think it's actually the second document down in the list of documents that then appears on your screen. And that document has recommendations on what you can do when there are no breakpoints in the breakpoint table.
Great, thank you so much, Bob. And then there was a question, I think, from our animal health sector colleagues. They are kindly asking where they can find any guidelines for EUCAST for the veterinary sector.
And that's a very good question. And it's something we are constantly now working on. And we actually work very closely together with our veterinarian colleagues. There is a EUCAST subcommittee called VetCast, not very surprisingly. The chairman is Peter Damborg, and you will recognize, I'm sure, many of the names on that committee. I urge you to write to them and ask them, you know, when will we see the first breakpoint table? Because it's an email I send to them every 3 months and say, have you not finalized this now? Because it's so close, you know, it's so close that you must expect to see a breakpoint table and their recommendations within the next few months.
Sure. Then there's another question. Someone is just asking if you could please re-explain the ecological cutoff points and also what to do for having a NACS. I'm not so sure what that is.
Having
a NACS, perhaps, if you can.
NACS, a NAC, yes, a NAC. So let's start with the ECHO. When many people use the same method for performing an MIC, it's not surprising that they all get roughly the same result. okay? If you send me a recipe for, a dish, and I practice for 25 years making that dish, a soup or a stew or whatever, you will eventually, after 25 years, say, you've got it right. It tastes the way it should taste. And it's the same with the MIC. We can actually get the same MIC around the world for a certain bug and a certain agent, just because we practice, we use Muir-Hinton from the same sources, and we try to control all the ingredients used for performing an MIC. And then when you put all that data together, you will discover that it's either monomodal, because there is no resistance whatsoever. All the strains that you have collected are all wild type, have no resistance mechanisms, and you will see a Gaussian monomodal distribution, very similar to the one I showed for example, cefotaxime, except then we had some resistance already.
Yes, please go ahead, Prof.
Yeah, where that distribution, that monomodal distribution ends, that's where the ECOF is. That's the epidemiological cutoff value. So it's really where isolates without resistance mechanisms, the MIC values they present, where that ends. And I'm not sure whether I can share again. Can I share again, do you think?
Yes, please, Fitsam, can you allow Prof to share again?
And let's see if I can back up here. I can only go, no, here. So this is a good example. So this is something you're all up against. It's E. coli and it's cefotaxime. And I put it to you that irrespective of where I collect E. coli in the world, they will distribute in a very similar fashion. And the blue bars will be identical. The proportion between the blue bars and the red bars will differ in different parts of the world. But the actual position, if you like, the MIC values of the blue bars will be the same on the west coast of India as in Australia, among E. coli from seagulls in Chile, seals in the Black Sea, women with urinary tract infections all over the world, they all distribute exactly the same. The only difference being that the proportion of red bars in relationship to blue bars will be higher in some areas of the world because of higher degree of resistance than in other areas of the world because of a lower degree of resistance. But the ECOF is the same. It's 0.25, irrespective of where we collect those E. coli. And you can see down in the right-hand corner of every graph on the EUCAST website, it says something like 10,487 observations. Observations are MIC values from 44 data sources, where data sources are investigators from all over the world. It's in the literature, publications, it's from animal programs, it's from surveillance programs, it's from Sentry, it's from all over the world, it's from development programs from industry, etc., etc. So we are not picky when it comes to accepting data from anyone and everyone. We are picky about the quality of the data, and nowadays we can assess the quality by just comparing one distribution to another distribution. So that's how the ECOFs are developed. And that's how the MIC distributions available to all of you freely are developed. Then let me just say that NACs, what you need to do when it comes to organizing and forming a national AST committee is you need to pick up the phone or your email, and you need to find a number of colleagues who all think, that would be a good idea. Let's form an NAC. And then you need to maybe phone your health department or, you know, some colleagues in the reference laboratory or, you know, whatever. And you say, we would like to form a NAC because we think it would be a good idea to have a national AST committee which can communicate with EUCAST, be part of the consultation process, help translate documents, help advise locally, maybe help with education of laboratory staff. All of that is what the NACs, the 40 NACs, which are now available around the world, and you can see descriptions of them on the EUCAST website. Again, you go to organization, you go to national AST committees, and you can see descriptions of the Australian NAC and the Moroccan NAC and all the different NACs that have already signed up have also normally created a website or at least describe their activity. So if you're good at Chinese, for example, there is a complete Chinese NAC webpage and document translating all EUCAST recommendations to Chinese. And I have signed them, not knowing exactly what I signed, but I have signed them, and they're out there for anyone to see. So I would encourage anyone who's interested in trying to make AST a national standard and being performed in a standardized way to allow comparison both inside the country and between countries. It's such a good thing to have a NAC for discussing all of those things, but also to serve as a go-between between national laboratories and EUCAST. And we're happy to come and visit NACs. We're happy to take part in national workshops, etc., etc.
No, thank you so much, Prof. Kahlmeter. So due to time considerations, we would really like to thank everyone who has shared comments and questions. At this time, I would like to give a few minutes for Prof. Kahlmeter to just provide some closing remarks. Please note that to download the certificate for attending today, the link has been shared on the chats. So, Prof, please, any closing remarks from your side? Thank you.
Just to say, it's been a pleasure to be with you. I wish I could, as I said, I wish I could, well, I wish we all had been able to meet, and I realize all the complications with that and the difficulties with everything from money to passports and visa and God knows all that. But it would have been nice to be able to share a lunch or a dinner with all of you and to just chatter away over, I'm not allowed to say a beer, but I'll say it anyway, to chat over a beer or a breakfast or whatever. We couldn't, but this was the best we could do at this point in time. And let's hope we meet at either maybe ECMID or ESMID Global. It's now ESMID Global, or for that matter, ICC in Istanbul in November, where I will be and give at least 2 talks. So it's been a pleasure being here with you, and thank you so much for listening.
Sure. Prof. Kahlmeter, really on behalf of the ASLM CoP team, really been a pleasure and an honor to have you on board. We look forward to engaging you again, so we might call upon you again to come back. But otherwise, really, it has been a wonderful session indeed. We are always, again, looking for ways to expand the knowledge base of the participants who come onto these sessions. So please stay tuned for the upcoming ASLM AMR CoP webinar. And as I mentioned, there's going to be a part 2 of this, as Prof. Gunnar has mentioned, that will be coming up next week, Friday. Otherwise, really, from ASLM and the team, wishing you all a great weekend ahead. Until next time, goodbye for now.
Goodbye, everyone.